This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello and welcome to the Neurology podcast. I'm Jessica Ailani, Director of the Georgetown Headache Center and Professor of Clinical Neurology at MedStar Georgetown University Hospital in Washington, D.C. We will be discussing spontaneous intracranial hypotension. And for this conversation, I have the pleasure of being joined by my good friend and colleague, Kathleen Digre. Kathleen is a distinguished professor of neurology, professor of ophthalmology and visual sciences, and an adjunct professor in anesthesiology and OB-GYN at the University of Utah. Hello, Kathleen, and thank you so much for joining me.
Thanks, Jessica. I'm so happy to be here.
So we're going to be taking some time to discuss spontaneous intracranial hypotension in clinical practice. So Kathleen, how would you say the diagnosis of SIH has changed in the last decade?
Well, Jessica, I think that the first thing is awareness. Everybody knew about post-lumbar puncture headaches. Every neurologist who's ever done a lumbar puncture has seen a patient with that. Really, the change is that this can happen spontaneously and just out of the blue can start as, let's say, a new daily persistent headache. And this spontaneity of this happening with even activities of normal daily life is something that we're just starting to understand. Secondly, imaging. In the old days with CT scans and early MRI scan, we really didn't have a good handle on what were these imaging findings. And now imaging really helps us make a diagnosis of spontaneous intracranial hypotension. And we know now to look for those things like cerebellar tonsillar descent, pachymeningeal enhancement, enlargement of the pituitary gland, and subdural collections, and prepontine cistern flattening, and so on. And that is really a big difference. And now people are really recognizing it. They're grading it. They're categorizing it. And then I think the third thing is imaging the leak has really changed. The technology has changed, and our understanding of leaks has really changed as well. In the past, it was kind of like, well, maybe there's a meningeal diverticulum someplace that could be the leak. And now we're finding out that, well, those little osteophytes can pinch the dura and pierce it and cause a little leak. And, other spinal disease can be going on. And then this whole concept of CSF dural AV fistulas, like in the spinal, where the CSF just goes into the veins and creates a leak. So I think those to me are really those three big things that have happened in the last 10 years to change our understanding and thinking about spontaneous intracranial hypotension.
The whole idea of the spine being so involved in CSF leaks. When I was in training over a decade ago in fellowship, we didn't really talk about the spine. It was all about brain imaging. And I do find it fascinating. We have so many more words when talking about SIH. There's a lot of like blebs and phlebs and all this other stuff. And I'm like, what is this? But it is all these areas that are hard to find anywhere along the spinal column where CSF can be hiding. I think of it as hiding, but that's not really what's happening. And it makes you wonder if, the 3D imaging and watching active flow is really where we need to be going with these things. And in the time of AI, I would love to really see imaging techniques start to change. And I find this for our radiologists to be very hard, very, very hard. I watch them struggle trying to come up with ways to look at this in a dynamic manner.
And I think that's a key point, is that not every center has this dynamic imaging going on to look at a slow leak or a fast leak. And it really is tedious. If you talk to the neuroradiologist, it's hard to find these leaks in certain people. Sometimes it's easy. You can get a heavy weighted T2 spinal image and, oh, there's the leak. You can put a directed blood patch right at that leak and stop the whole thing. But a lot of the time, it's not that simple. And you have to do this dynamic CT myelogram, and you have to know how to look for these very difficult leaks that some people have.
Moving away a little bit from imaging, because I think when you see it, and you make the diagnosis, and then you can put all your time and energy in trying to fix it. But what happens when we don't see it, which we're learning with evidence, and there's really quite an abundance in the last few years of evidence showing us that we might not see a leak, but it is there. When we don't see a leak on spinal imaging or brain imaging, yet a patient has clinical symptoms, what do you think are the more important clinical symptoms we should be focusing on? When we see a patient with these symptoms, we really need to start deeper investigation.
Well, I first look for the classic postural headache where it's better when they're lying down. It's better in the morning. It gets worse as the day goes on, and they can get better if they take a nap, and so on and so forth. But there are things that can confuse us. Let's say you get that story. What else causes a headache that sounds like a leak, but it's just not a leak? And here I kind of go in my brain and I kind of have a checklist. I look for cervicogenic headaches because sometimes those can be positional, cranial cervical instability, and sometimes you have to look for that instability in certain people. Then postural orthostatic tachycardia syndrome can mimic low pressure headache. And then headaches with autonomic features can also be kind of fooling. And people want to lie down because they've got autonomic features when they're standing up. And so those are kind of my little checklist. If all that imaging is negative and nobody's finding a leak, wow, have I missed one of these other diagnoses that should be treated completely differently? The second thing I really look for is a new daily persistent headache, because a lot of these people come to you and say, on this date, I developed a headache. And here, neurologists are such great historians. They can go back to that day and say, okay, let's take that day. Let's talk about what were you doing? What activities were going on? What was happening during that time? And then you also have to query for other symptoms like a little bit of vertigo, a little muffled hearing. Maybe they have a little new diplopia. These are symptoms of low pressure or spontaneous intracranial hypotension. So those are my clinical features that I go after. But as neurologists, we're so good at history. We can go back and I go, okay, we got to recreate this day. Were you out fly fishing? Did you do a yoga posture that day? You have to ask about these activities of daily living that could be something that happened, or maybe they had trauma a few days before. And those are the kinds of things that can lead to a spontaneous CSF leak.
So, say you have a patient come in and they give you this story of new daily persistent, and then I recall this one patient early in practice in her 60s, new daily persistent headache, could tell me the exact day. And when I asked about trauma, she said, nothing much happened, but I remember I was walking my dog and my dog yanked me a bit and I kind of tripped. She didn't quite fall, but she had this something, and I felt, let's get some imaging. How do you start that workup? What's the first test that you would order in a patient that you're suspicious of a CSF leak?
So, in a patient that I'm suspicious of a CSF leak, I get MR brain imaging. And I get it with gadolinium because that's going to show me pachymeningeal enhancement. It's going to show me the veins if they're dilated. It's going to show me the pituitary gland, but it's going to be an MR image. And Jessica, one of the things I've learned in my career is if you let the neuroradiologist know what you're looking for, we can help them a whole lot in being sure that they don't miss subtle signs of a CSF leak. And because if they don't know what we're looking for, sometimes these can be really subtle, like a little flattening of the pons, a little bit of tonsillar descent, little pituitary engorgement. It can be subtle. So letting them know what you're looking for is a critical piece of getting the first test done. The other thing, before I even order the test that I do in my office, is I will do a patient in Trendelenburg for 5 minutes. I don't know if you've done that in your practice, but sometimes that's helpful. Like you put them in Trendelenburg, head down position, and they say, oh, I feel so much better. Or they, even if you can't do that, have them lie completely flat.
Yeah, actually, we often find when you walk in the room and they're already like our tables no longer go in Trendelenburg, but if I walk in and they're already flat and they tell me I can't sit up for too long, to me, that's just that's just it.
That's
I don't have to even start with the history. I'm like, okay.
yeah, I know. I know. If they're on the
It's not
floor,
often.
I
Yeah.
have had many patients on the floor going, "I'm sorry, I'm on the floor, but if I sit up, I just have the worst headache of my life." That's a real finding.
It's funny because you don't often see migraine patients do that. They will sit, the room will be dark, they'll sit there, they might throw up, but they don't lay flat. They will not actively put the table down to lay flat. But all of the SIH patients, every one of them has flattened the table out. And I feel like it's almost a sign that there's something off. And
Totally agree.
there's a positional. They might not have a leak, they might have one of the other things you mentioned, but it really does tell you a lot about the story. So you start with the MRI brain gadolinium. Do you ever automatically also order spinal imaging, or you first wait?
Sometimes I do if the story is just so classic and I just go, well, I know what this is. I might go ahead and get that heavy T2 weighted spinal imaging because that can tell us something. And of course, they get gadolinium for their brain. So they're going to have a gadolinium enhanced spinal image as well. But you want to ask for a heavy T2 weighted image in addition and make sure that neuroradiologist knows you're trying to look for a CSF leak. But sometimes, if the story is like, well, I'm not sure, I might just go with the brain first. And then if that shows signs, for sure, I'm going to get spinal imaging. And let's say that doesn't show anything. Let's say it's normal. What else could we do? Well, some people recommend getting a lumbar puncture and checking the opening pressure, but that isn't always that helpful. Many times they don't have a low pressure on a lumbar puncture. Um, in our institution, we can do a cisternogram, which is a radionuclide scan. And the reason for that is not to find the leak, but to find that radionucleotide being collected in the bladder. And that tells you that it's been absorbed from the CSF into the body. And so it's in the bladder, and you know that you probably have a leak. So it is another test you can do. It's not done at every institution, but it can be helpful in some individuals.
Oftentimes at our institute, we also just start with the MRI brain with gadolinium if the story is almost there, but not quite, and you're not really sure. And then we've been doing lateral decubitus MRI of the spine, T2 weighted, without contrast, without the gadolinium, to see if we can find anything abnormal. But again, under the guidance of our neuroradiologist who has an interest in this, it can be really tough to figure out the right imaging to order. There's a lot of different stories out there about what to get. And then what if you do have a patient, you're highly suspect might have a leak, and MRI brain with gadolinium doesn't show any clear signs. You're unable to get a burn score. And maybe Kathleen, you want to talk a little bit about this is something I've only learned about in the last few years, what a burn score is and how that can help us grade if a person might be at risk or does have a CSF leak.
There are these scores that people have devised where they give certain number of points for every finding on the MRI scan. And I sometimes find that helpful, but not always. I mean, you have to look at every single finding and then you have to make a clinical judgment. So the burn score is helpful, but it's not perfect. I would say that sometimes if I'm really convinced that they have a leak, I'll just do a blind blood patch and see if they get better. And I have to say that helps me probably the most because people who really have a CSF leak, they'll get the blood patch. And I know that there could be a placebo effect, but a lot of these people are just like, oh, this like changed my life, really, really helped. And I use that as almost a barometer for the spinal fluid leak. I don't know if you do that too, Jess, but boy, that really can be helpful.
We've been, after a number of different articles have come out talking about this and quality of life measures, improvement after blood patches, even if negative imaging exists, looking at patients who have orthostatic headache, don't have another reason for it, who might have other signs and symptoms of CSF leak like vertigo, muffled hearing. And then we've been using the Stanford scale of improvement on rest. So they lay flat maybe for part of a day or a weekend, if that's even possible, and they have pretty drastic improvement in headache. Their headache is better first thing in the morning, and then 15 minutes after moving around, it gets worse. So we've been trying to measure these items, and in a patient who has improvement when being flat for a period of time and worsening as they move around, we'll send them for a blood patch. Unfortunately, this is really based on staffing. Like the less staffing we've had with neuroradiology, the harder it is to provide blood patching without positive imaging. I think that we've really hit a point where we're not having enough neuroradiologists to be able to do this. And we also have some trouble sometimes convincing patients after the first patch because blind blood patch doesn't work 100% of the time on the first try. In fact, in my career of doing this for a decade or so, with every time I've tried to send a patient, I would say it's the second or third that works. It's rare the first one does. And it makes sense. I mean, the patch only travels so far. You're kind of guessing the level based on a patient who's had a CSF leak, who knows where, because you're not really sure where this has happened. These aren't patients that necessarily have had a lumbar puncture. So you're kind of guessing where the area might be. And it's tough. And so the patient has one and they're like, oh, I don't know if I want to do that again. It was maybe only partially helpful for a day or two and took out time from my life. And you have to talk to them about like, listen, you're really disabled and we have a strong feeling this might be what's going on. And you have to have some faith.
Talking them into that second or third one.
Yeah.
I'll tell you another thing. Normally, you like neuroradiology to do it because they can do it under guidance and all this kind of stuff. But you know who else is really good at blood patches? Anesthesiology. They do these all the time because they do epidurals and then they do spinals and then they do blood patches for these procedures all the time when the patient has a, let's say, post-dural headache. They do these. They're really good. So my tip is make friends with your neuroradiologist, but also make friends with an anesthesiologist who's willing to do a large volume patch. That's another issue, is getting somebody to actually do a large volume 20 cc patch. That's a lot of blood that they take from the person and then put it in and hope that it kind of spreads up and down the spine and stops the leak. The other things I've learned when I have patients who I think have the leak and I'm going to do a blood patch, I tell them a few things. One, stay hydrated, because if you're dehydrated, then that's going to be harder to get that patch to work. Second is caffeine. Caffeine can actually be very, very helpful. We've treated even people with post-lumbar puncture headaches in the old days with caffeine sodium benzoate and really help their post-lumbar puncture headache. So that's another thing that they could do, is a little extra caffeine. And sometimes an abdominal binder can even be really helpful. It may be a little uncomfortable, but it can be helpful. And some of these people are so desperate because their life is a mess. They can't really function. They can't work. So a lot of the people I see, they're very happy to come up and do whatever I'm suggesting so that they can feel better and get back to work.
Do you ever prehydrate them? Do you give them like IV fluids, a liter or two before they go in?
Well, it depends on if, let's say, they haven't been drinking because they've just been so miserable.
Yeah.
Maybe that would be a good thing to add to the protocol. But I don't do that routinely. It depends on each individual. And then just getting that blind blood patch is not easy sometimes to get. And if you've got a spot on your imaging that you think could be a leak, then you want neuroradiology to go in there. And that may be tricky because they really do need x-ray guidance with a needle to know where they are. They're going to have to use dye to figure out exactly what area they're in, and then they'll put the blood patch in right at that area. But that does take some skill, I think.
So, Kathleen, my last question to you. Say you have a patient that you are very suspect of a leak and you do want to send them to a specialty center. Say they are interested in going to a specialty center. They want to make a travel out to the Carolinas or maybe to California to one of these large CSF leak centers. Do they have to have abnormal imaging, you think, before they go to one of these places? Or can their imaging be normal?
Well, it's a case-by-case basis. And I have talked with Walter Shevank in California, and I talked to Linda Gray in North Carolina, but it's a case-by-case basis because sometimes the imaging is not quite convincing. As a neurologist, you may be responsible for sending the imaging so that they can look at it ahead of time. And they'll say whether they want to take the case or not. Sometimes they'll take it, sometimes they won't. But not every center is used to doing these really tough cases. And sometimes it's really helpful to go to one of these centers. And I think there's more and more popping up because there are more neuroradiologists now that are getting interested in this problem. And sometimes there are neuroradiologists and neurosurgeons wanting to be involved in this problem, and they're willing to do that. So it really is, I think, a regional thing. If I were a general neurologist, and I would go do some research of my region and find out who's interested in this topic, who's written articles on it, who's done studies on it. And many people in headache clinics will know where to send the patient. In our center, we know exactly which neuroradiologist at our center loves doing this stuff. And then we work with that person to get the patient in when they're on and when they can do the dynamic myelogram and all that. But I have to say, it is sort of a case-by-case basis, but be prepared to send records, send information, say why you think this is what the diagnosis is, what's your evidence, even if the imaging is negative, because those people know that you can have negative imaging and still have a leak, but they're going to want to know the story.
I agree. I have found that the imaging doesn't have to be abnormal, but the story has to be convincing. And you do have to advocate for your patients. And I've always been impressed where our imaging will be normal or whatnot, and they actually will review your imaging and be like, no, it's not normal. Do you see this? And you're like, oh, look at that. No, I did not know what that was.
Well, a neurologist sometimes is the person who looks at the imaging and finds things that people missed. Yeah. That's why all of us are kind of neuroradiologists too. Every single one of us, we have to be. The other point I'd like to make is if you're at a center, it is not a bad idea to have kind of a protocol. Get a team, because this is team medicine. You need a good neuroradiologist who knows what's going on. You may need a neurosurgeon that understands what's going on. You may need that anesthesiologist to do that lumbar large patch for that area because you don't have anybody else that can do it. So we've developed actually a little mini protocol that we worked out with our neuroradiology colleagues, our neurosurgery colleagues, and then we have this team. And boy, is that helpful to have a team, because then you're not out by yourself. Because even if you fix this leak, the headache can persist.
Yes.
And then it's up to us to help get these headaches under control. And many of these people have underlying migraine or other headache disorders that get triggered by this leak. And they are not going to be like completely miraculously 100% cured. They're still going to need our help in getting that headache under control.
Well, Kathleen, I just want to say thank you so much for this amazing conversation about SIH. This has been the Neurology Journal podcast, and we've been talking about spontaneous intracranial hypotension. And I've been joined by Kathleen Digre from the University of Utah. I hope you've enjoyed our conversation and you listen on in the future when we talk about IIH.
Thank you so much. I've really enjoyed being with you, Jessica.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.